Out inner branch stentgraft for pararenal aneurysm. Please, Ark.
Okay, thank you. Good morning, everyone. First of all, I want to thank Professor Nasser Al-Said for inviting me here for this interesting symposium, and also Said Ali for showing me and guiding me here to this meeting. My topic, as you can see here, is the inner branch stent graft for the pararenal aortic aneurysm, and I'm going to speak about the off-the-shelf stent graft. These are my disclosures, and I want to focus a little bit on the types of the stent grafts for the AAA repair. As you can see here, we have two types. One is a custom-made device, and another one is the off-the-shelf device. The custom-made device has certain advantages like fitting the patient's anatomy, but it requires 6 to 8 weeks for customization and preparing the stent graft. It can be fenestrated, it can be branched, and if we speak about the branch stent graft, it is usually the outer branch or inner branch. On the other side, the off-the-shelf stent graft is developed based on the relative predictability of the renal mesenteric vessels. And these stent graft can be usually branched. We do not have any fenestrated off-the-shelf branch, and they can have the outer branches as well now, the new one with the inner branches. And I am going to focus a little bit on this new inner branches stent graft. So what are the advantages of the outer BVAR? This is the flexibility. Currently preferred approaches for the type 2 and 3 thoracoabdominal aortic aneurysm. They provide a better sealing and fixation for the bridging stents, and this is less critical positioning of the branches in the stent graft. If we look on the other side of the fenestrated EVAR, that requires less space, and so that means is devoted for the narrow aortas that currently is used for the type 1, 4, and 5 thoracoabdominal aortic aneurysm, and the technology allows us for the minimal aortic coverage. So where is the place of the inner branch BVAR? This inner branch BVAR can be used in complex narrow aorta because there is no risk to squash the branches. It is very good for the post-dissection procedure in thoracoabdominal aortic aneurysm or dissection, and to repair the failed previous FIVAR in different cases. Some people used to say that this is also good for the all cases with so-called awkward takeoff of the visceral vessels, but that we can discuss later. What I'm going to present to you is an insight, a new stent graft from the Jotec company, which was already discussed yesterday by one of the speakers. It is designed in such a way that we have 4 inner branches inside, and if you see here on this side, the important thing is the outlet of the inner branches, which has a shape of the oval, and that gives you a little bit more movement of the bridging stents. This is the whole stent graft when it's deployed. What you can see here, some inside catheters, because this is the preloaded stent graft. You can use the 014 guide wires then to push through the cannulas inside, and then make it easier to cannulate the inner branches. There are 2 sizes. The middle portion of the diameter is 24 millimeters, and it's very stiff, in fact. But the main body can be of 38, 33 millimeters, and the distal diameter of that is 30 to 26 millimeters. What we see here, these are the branches. CT and SMA is 8 millimeters, left and right is 6 millimeters, but the length for all of them is 20 millimeters. So, important thing is the positioning of the branches, as you can see here, but the important thing is that thanks to the oval shape of the outcome of these inner branches gives you additional angles, so you can move the bridging stent up and down, left to side, just to better align the bridging stent to the distal vessels. So look, what are the differences in the sequence of stent graft deployment? The important thing for EVAR, inner branches and out branches, that the first two are very similar. So that means that device insertion and stent graft deployment. But later on, the outer branches, you remove the device, you extend toward iliac vessels, you close the common femoral artery, and then obviously you cannulate the visceral vessels. With the inner branches here, first you have to keep the device in place, you cannulate the visceral vessel, and finally you remove the device. So device is staying in the aortic bed quite long. My personal experience is 10 patients, mean age is 69, and the indication for the treatment was in 9 cases pararenal aortic aneurysm, and 1 was thoracoabdominal aneurysm. And these are my data here. So as you see, 10 patients. The one of them had only thoracic stent graft inserted, and all of them had the inside. You see the bridging stent graft. At the beginning, we used the EVC2023, a part of the Jotec technology, but unfortunately, then we had to switch to another because the EVC2023 is not strong enough to maintain a good quality of the bridging stent. Then we extended everything with the Integra and then the other branches into the iliac arteries. We used the iliac conduit because the iliac vessels were too small in 2 cases. So let's see one of the cases. You see here the pararenal aneurysm, as you can see here, on the level of renal arteries with a good iliac arteries. This is the way how we place the device. The device is inside of the stent graft. The important thing is that you have to snare through and through guide wire through the cannulas, which are preloaded. That's usually 014 guide wires that allows you then to cannulate with a special catheter inside of the renal arteries. You then deploy the stent graft here, and you do the same thing on the other side of the renal arteries. You cannulate in the same way the CT as well as SMA, and this is the completion angiogram showing you the final result without any endoleak. And this is pre-op and the post-op result of one of our patients. What is the personal experience? The technical success was 100%. We used in 2 cases the iliac conduit. Look at the mean time of the procedure. Skin to skin without conduit is 256 minutes, and no conduit 225. And the important part of this is mean hypogastric occlusion, which was in the meantime 90 minutes. So it means 1 hour and a half. It is a long time. Mean contrast volume used is around 100 millimeters. Mean fluoroscopy is 72 minutes. Mean blood loss 300 milliliters. Mortality 1, and the paraplegia 1. This is the same patient. So she developed the paraplegia and then and unfortunately died. If I have just the last slide, just to conclude, I need 10 seconds, and that's, I'm sorry. Thank you. Thank you very much. So in conclusion, ladies and gentlemen, I have to say that the new stent graft is friendly designed. This is the off-the-shelf stent graft, easy to use, easy to implant. The precannulation of inner branches, it can be helpful for the beginners, although it takes additional time to learn. But for the experienced surgeons, I don't think that this is really a big advantage. Time for hypogastric occlusion is too long, so that can be of certain issue. And this is for sure a new era of stent grafting, but it requires more data and more experience. Thank you very much for your attention.
I should thank you for a great presentation.